retreat for yoga and brain disorders in one of the conference. And then today is this, and tonight I am doing a completely different program called amyloid PET scan for Alzheimer's disease. So one of my friends was asking, how do I keep up with all the different topics, and do you prepare? So one of the things that I always believe, no, I don't prepare. I think when you have the passion and when you have the heart, what you believe in and what you're doing, you don't need a preparation. You don't need to fake. You can actually talk from your heart. So this is a talk from the heart, and I don't want you to focus on a lot of the neurology nomenclature, a lot of the neurology terms that I'll be using. I don't expect you to remember all of the name of the brain areas or different domains names. You know, leave that for a lot of the neurologists to work on. But the reason for this talk is not about the brain anatomy to talk about. I will talk about the brain anatomy so you understand the connection between the cognitive domains and each of the brain areas, but not necessarily you need to remember and memorize those for yourself. One of the things I want you to take home though is, with the passion, with your heart, the thing that you need to learn to look at our patients differently, look at our residents differently, look at them from the viewpoint, of course with the heart, open heart, but also with the neuroanatomical model that their behavior sometimes they act or they do something not necessarily they wanted to do, but they do it or they act that way because of this neuroanatomical dysfunction in that pathway. So this is something I want all of you to take home, and I'll give you a lot of examples in real life examples so that you learn better. All right, so with that, first couple of systems that I'm going to cover. I hope a lot of you were in my part 1, neurocognitive domains, which I covered the attention and executive function, which is right front part of the brain called frontal system. So I'm not going to review everything from frontal system because of the time, but we do have a recording, I believe, Allison. So please feel free to go to the Institute website and if you need to update yourself. So today's talk is the other domains other than executive function. So the next one, of course, the memory that we all know. And the purpose of this series is really to educate everybody that memory is not the only cognitive domain. So don't get fooled by people who doesn't have a memory problem and they have severe dementia, because these are the folks that never get diagnosed because they scored 30 out of 30 in mini-mental, which is the memory scale. Their problem is not memory. Their problem is the other domains of cognition. So this is what I want all of you to focus on, that memory alone is not dementia. We cannot call. But having said that, memory is the major domain of cognitive functioning. And that is in the areas of the limbic system, which controls, learn, the new encoding, new registration, everything that we learn, like you learning every day right now. Everything that I'm saying, your hippocampus, the main part of the learning center, is picking up. However, it's never going to register until you go home. I think I gave the example last time, until a chemical glutamate comes and activate a process called learning process, or EPP, or it's a excitatory component for learning in the glutamatergic system in the hippocampus. It's never going to happen until you sleep. So sleep is a major functioning. Sleep is a requirement of learning. So if you don't sleep, you never really, whatever I said is going to go away, because it's not going to last longer, because the glutamate would not come and host the hippocampus to form that long-term memory from the learned process. So we talked about that last time, that how sleep can be misdiagnosed, sleep disorder, as dementia disorder. So sleep is an essential component. So the memory comes with this whole pathway. This is a memory pathway which goes from hippocampus to this area mammillary body, which is another part of the hypothalamus, which is another basic regulatory part of the brain. It comes to the fornix, comes to frontal lobe, which is called cingulate gyrus, and it goes back to the hippocampus. So this is a closed loop circuitry, like electric circuitry that you do with lot of chemical, electrical engineering people does it for circuitry for a electric pump or anything. Brain does exactly like that. So it's a closed loop circuitry. But I'm also going to talk about something other than memory, which is the spatial understanding where you are. So I am standing in front of you. In fact, this is going to be the first topic that I'm going to cover, because a lot of us, including the primary care physician, unfortunately don't get this understanding that why people are falling until they understand this kind of functioning of spatial dysfunction. They're gonna miss a lot of the falling reason, and they're gonna have $1 million workup unnecessarily when their actually problem is the spatial functioning, which they are ignoring. So this is a really key area I want you to also learn about today. So the spatial functioning, the geographic orientation, where we are located, where we are in the environment, what is our relationship with all of us around us, this is called spatial understanding. So when you drive a car, you have to drive in between lines. You have to have certain space between cars. How do you do that? This is the part that does it, parieto-occipital cortex. So parieto-occipital cortex is where they call it where pathway. Where pathway means where you are. So this is the pathway in the brain that determine where in the environment you are. So if you are too close to a car, it tells you you are getting too close, space out. So you come back off. You are too close to the car. You are too close. You're not in between line. So this is why the driving becomes a problem in dementia, because of the spatial understanding. So a lot of my patients say, oh, I drive fine. And their family says, oh yeah, actually driving is not the problem. No, driving is not the problem. It's not the maneuver is the problem. It's the spatial understanding, depth analysis, the understanding between space. You'll see a lot of people also come, even if you're a nurse working in a nursing station, come like close to you. Like, I need this. You say, all right, I hear you. Can you back up? The spatial understanding, how far are you from other, become very difficult to analyze when you don't have this functioning running in this area. This is also the part of the brain controls the visual processing, connecting with the space. So if I see a chair, my visual center, the eyes light up the visual part of the brain called occipital lobe. Occipital lobe then connects to the parietal cortex, which is our spatial brain, and these visual processes talk to the spatial processing and then transmit back with our motor functioning that I should back off because there is a chair in front of me. Otherwise, I'm going to fall. I'm going to trip over to the chair. If this talking does not happen, my eyes are fine, but I'm almost like I'm missing the chair. I'm not even seeing the chair. So I'm going to fall. I'm going to trip over. So this is why people get disoriented in their room. Sometimes they get in other room and we feel like, oh, they're going for, a lot of, if it is a man, we miss such state that, oh, well, this is probably, sexual behavior, this behavior, that behavior. No, it's not. It's actually spatial understanding, geographic disorientation, not knowing where you are in the environment. So there is no need for a pill for that. You have to redirect them and understand and make sure that this is not going to get better. So a lot of assisted livings, I hear that they don't take patients because they're urinating in public places. We cannot tolerate that. Don't call you assisted livings and dementia care center if you cannot provide residents care for who are unable to understand where the bathroom is. It's your job to find out and direct those residents to your care. Otherwise, don't call that as a dementia care center because dementia comes with that behavior. So it's like you can't have a dementia with a beautiful behavior, like a pleasantly confused patient. You can get that few, but no, that's not the right of dementia. The right symptom of dementia comes everything together. So if we are caring for our resident with the heart, with the passion, and calling ourselves the caregiver or the Center for Alzheimer's Disease or Dementia Care, then no, those are not excusable. That I'm not going to take that resident because they are violent or aggressive. I'm not going to take the resident because they are urinating a place. No, because then you cannot call them. That's not the way to treat our resident or our patients suffering from this terrible disease. So this is where the where pathways is. So this is my passion talking, because I see that all the time, and I get really frustrated about this discrimination of patients suffering from this type of diseases, because it's not somebody's behavior you should see, it's the cause of the behavior you should see. And our focus should be, how do I modify that? How do I train the brain in a different way so the person doesn't urinate everywhere? We can train their bladder so that when I get a cue that he's about to urinate, I can redirect them to the bathroom so they don't have to urinate. And that is called wonderful behavioral redirection for this type of spatial dysfunction. Not like yelling at them or giving a pill to make them, no, there is no pill for that. So I wanted you to all focus on that where pathway is the pathway where you are in the geographic orientation, where you are in your spatial orientation, and also where you are in terms of your gaze. So this is the pathway, also controls our voluntary gaze. Voluntary gaze means if I wanted to have you look at me, come on, look at me, and you are actually looking at that way, so look at that way, and you say, yes, I am looking at you. I said, no, you are not, you are looking at the other way. They say, no, I'm not, I'm looking at you. So their gaze does not voluntarily go where the object is. Do you understand that? This is called gaze apraxia or oculomotor apraxia. So I'm going to touch a little bit on that. There is a syndrome called balance syndrome. It is one of the fantasy of almost all neurologists, two syndromes. One is the balance syndrome, and the other syndrome I'm going to talk called Gerstmann syndrome. We all fantasize all our life in residency when we're doing neurology that I wish I could see a patient with full-blown balance syndrome. It's hard to see all of the features together, but I have seen that, and I think you can also, that if you really look at that. So there are three components of this. The first component is what I just told you, called oculomotor apraxia, which is basically gaze apraxia. So if I ask you, look at me, they can't look at you directly. They're looking at somewhere else and saying that I am looking at you, but their gaze actually doesn't look at where the object or where the sound coming from. Okay, so this is a really one of the difficulty in fixating eyes. It's not an eye problem again, it's a problem with the parieto-occipital cortex. Just remember. So they don't need an eye appointment. Optic ataxia is another. Optic means eyes. Ataxia means, again, inability to move the specific object by voluntary gaze movement. So, for example, I am doing a little, if you want to be my subject. So, touch my finger and touch your nose. Okay, touch my finger again, touch your nose. So when I asked her, she looked at my finger, she touched my finger because she knows where my finger is. So now, in optic ataxia, this is a test we actually don't do for this purpose. This is a test we do for cerebellar function. Like, you see that SCOPS does it, on the sobriety test, because that's a cerebellar function. When you have alcohol, you dysfunction the cerebellum, so you get ataxic. You can't really do this kind of stuff. But I'm not doing it for that purpose. But this test can also be done for that purpose, meaning she cannot locate where my finger is. Once I can show her where my finger is, then she has no problem coming back and forth to find my finger. So it's not the ataxia, the regular sense like cerebellar ataxia. It is called optic ataxia. It's an eye ataxia. Again, it's not an eye problem, it's a brain problem. It comes with this balance syndrome. Why the problem is, this is becoming a problem during meals. If you are eating with a knife and a fork and not supervising our residents in the mealtime, and sometimes the other one, oculomotor gaze apraxia, they can take food from somebody else because knowing the other's plate is their place, or they have difficulty focusing the object on their own plates. Okay, so it can cause a lot of accident, choking, and all kind of accident you can precipitate. So optic ataxia is the second, and then the last one is called simultaneagnosia. Simultaneagnosia is basically simultaneous agnosia. If you break down, that's a nice way of having Latin word in medical field that you can actually break down and understand so clearly that it's not hard to understand. Simultaneous means multiple together, multitasking, agnosia. So say suppose I'm looking at a picture, this picture. Can you all look at this picture? What do you see in this picture? Can you say? Okay, so if I have simultaneous agnosia, I can only focus on one little thing in the picture. I cannot focus on the overall picture. I can say it's a picture of a beautiful mountain or beautiful countryside or something that, or an ocean, or if it is a beach picture, I can only focus on. So if somebody's playing on the beach, like two little girls playing on the beach, somebody's laying on the beach, a dog walking on the beach, and you ask them, what do you see in the picture? You know, most of us will say it's a beautiful beach picture, you know, but they can only focus on one. They can only say, I see a dog, or I see a little girl there, and they can't appreciate the whole perspective of a whole picture. So it's the inability to perceive the visual field. Their visual field becomes very narrow and just focusing on one thing. So these are three things together is called balance syndrome. So gaze apraxia, optic ataxia, and simultaneous agnosia. The other one, the fantasy that I was talking about, is called Gerstmann syndrome. Again, I have seen that one, and you know, if you look correctly in our resident, you will see that too. It's mostly happen with a stroke or a head injury. It can also happen in dementia or any dementia, including Alzheimer's disease, depending on if you involve this parieto-occipital cortex, which is the area that I'm talking right now. It is again involved all of things together. Number one is alexia with agraphia. Alexia means inability to read. Agraphia means inability to write. So this is happening. I saw a patient with PhD in Oxford. So you can say how good his PhD, you know, English, grammar and everything. And he has this, he could not even read a little sentence. He lost the power of reading and lost the power of writing. So it's an alexia with agraphia. Second one is acalculia, inability to calculate. So if you ask them to multiply 2 times 3, how much is 2 times 3? They can't do it. They may have PhD in mathematics, but they can't do it. They lost the calculation skill, inability to calculate. So it's alexia with agraphia, acalculia, and then the next one is finger agnosia. Finger agnosia, inability to recognize finger's name. So you ask them, what do you call this finger? You know, a lot of my patients say, I call it a finger. I said, so what is that finger? That's a finger. I said, so what's the difference between this finger and this finger? No difference, they're fingers. So, so inability to recognize name of the finger, that which finger is what. And the last one is right-left disorientation. So if you ask them which one is your right side, they can't differentiate between right and left. All right, so what are the components of Gerstmann syndrome? Alexia with agraphia, acalculia, finger agnosia, and right-left disorientation. So every time you, as a nurse, if you're a nurse here, ask them to not please what you learned from nursing in backdated, like in 14th century, that what day, what month, what year, and you say, what do you say? I see that all the time. Oriented times 3. What is times 3 means? It means nothing. Please do not ever write times 3. That's annoying me so much. Because times 3 maybe for me means I'm asking it what day, what month, and what season. Times 3 means different things to different people. So please, if whatever, just describe in English term. Don't use medical term. Just say oriented to the date, oriented to the month, or oriented to the year. That's it. That's good enough. Don't say any, you know, that kind of technical term, times 3. It doesn't mean anything. So please first start documenting in your chart. Do not ever write times 3. That's the most annoying thing whenever I see a patient and see someone writing times 3. A lot of doctors does it. Primary care doctors does it all the time. They can't even write A. They write AO times 3. They're so busy. They can't even write the whole sentence, you know. Especially one doctor that in our facility, I could never read his handwriting. You know who I'm talking. But so no, nothing personal. But I think this is something that we should know, that everything that we do has to have some meaning. so that it doesn't need a documentation just because you're saving your butt that you worked. No, documentation means something. It has to mean for the residents' care. It has to mean that it has to carry it on to the next nurse so they can understand, and next nurse can tell the doctor, and then so they can understand. So overall, the care of the resident or the patients can get better. That's the purpose of the documentation. Not documentation for billing, not documentation because I just want to document that I worked tonight so I can pay it. No, you will get paid, but not this way. Don't worry about the payment and documentation. So this is something really important. All right, so summary of the parieto-occipital domain. So we talked about spatial attention. We talked about visuospatial function. One of the other things we talk about, that will be the end of this, is called neglect syndrome. Have you had people who neglect the other side? Have you seen them? So this is called contralateral hemi-neglect. Contra means opposite, lateral. Contralateral means opposite side of the body. Usually we use it for stroke. So if you have a stroke on the right side, you did a contralateral paralysis on the left. Okay, so it's the opposite side. So contralateral neglect, or sometimes we call it hemi-neglect. Hemi means partial, like hemiplegia. Hemi-neglect means half neglect. So it's not full both visual field, you only neglect one visual field. Usually the lesion is on the other side. So usually it happens from the right-sided lesion, so you neglect the left side of the vision. So if I'm like this, I don't see anything on the left. If you have severe neglect syndrome, there is a term we use called alien hand syndrome. Alien means, alien hand syndrome. So why it's called alien hand syndrome? And I actually had an example of that. I will tell you about this. Alien hand syndrome means sometimes they can't even recognize their own hand. They feels like this is somebody else's hand. They neglect so much from their other body. So I was a resident, and Marshall Folstein, who was, as you know, Folstein's Mini Mental, he was the director of the residency program. One day we were doing a round, and he was presenting a case in the ER. Patient has a severe stroke on the right parieto-occipital cortex. So he was asking that, oh, I hear that you had a stroke and you could not move your arm on the other side of the left arm. She said, no. One of the other things of this type of stroke or this type of brain injury is also called anosognosia, which is inability to appreciate your own problem, and it also called denial of illness. So they will not believe they have a problem. They will deny, and that's one of the components of dementia. So it's no problem, no point arguing with them that you have dementia. They'll say, no, I don't have a memory problem. My daughter just said, that's their problem. I don't have one. So this is what the problem. It's not like they're faking. This is the problem. This is the alcohol does that too, because alcohol also hit the parieto-occipital cortex on the right side. So you lose the insight orientation on the left. So that they coming back to the neglect syndrome. So that patient that has stroke, so when Dr. Folstein asked that you had a stroke, he said, no, I don't. So he actually pointed out, bring the hand and arm on the other side. And he said, oh, that's not my arm. That's somebody else's. So this is the extreme case of hemi-neglect, what we call alien hand syndrome. It's hard to get one of the extreme because you have to have bilateral stroke, both side stroke. So, it's hard to get that kind of stroke sometimes. You can get it, but it's not that common. So most of the time we get hemi-neglect. So they lose the visual field on the other side. I'll give you an example. Right here in Copper Ridge, 3 years ago, our staff is much more educated, and everything that we're doing just to get educated so we can be a better caregiver. So one of the things that I recognized 3 years ago, that I got a call from one of the unit here that we need someone behavioral management for some behavior, aggressive behavior. I said, what happened? So I went there, and let's say this is Mr. Smith. So Mr. Smith is punching somebody every time somebody asks them to, take shower or something, get out of the bed. So we need a pill so that we can take care of the ADL, so we can have a Ativan or something half an hour before the ADL so they can take care of that. So I said, all right, we're going to write everything. Let's see what happened. So I see Mr. Smith. Mr. Smith's bed is at the wall. So the wall is here, the bed is here. So the nurse always go on the left side because there's a wall, so you can't really go on that. So I said, so every time you ask, you are always here, yeah? They said, yeah. I said, how about let's put the bed in the middle? So we put the bed in the middle. I said, now can you go on the other side and ask Mr. Smith? Going down the other side, Mr. Smith didn't even punch. I said, so this is called classic hemi-neglect. There is no need for a pill for Mr. Smith. We need to educate ourselves, and that is our pill. That is not for the resident. This is our pill to get educated, to train. So this type of hemi-neglect can be interpreted as a behavior problem. So before anybody punch you or do anything, make sure their visual field is okay and they actually see you. So don't go, because what happens if you don't see someone on the right side and you are going on the right side, somebody coming on the right side and say, come on, let's go for a shower. What would you do if you don't see anybody and you perceive a threat? You punch out, yeah? That's our defense mechanism. So that's what they're doing. So before you even interpret anything, make sure that you are in the middle or in front of the patient or a resident, so patient's visual field can visualize you, who you are. And please introduce yourself, who you are, so they can actually understand why you were there for. Not just, come on, let's go for a shower. And who are you to take me for a shower? I don't want to take you. I'm not a baby. Why you ask me for a shower? You know, so this is something, a simple approach, how you can actually be a better caregiver. And this is something, a certification course, every nurse should do for every GNAs that work under you on the unit, so that treat everybody, understand what is called visuospatial functioning. You know, the executive function I talked last time, you know, you understand the sequential task. I think everybody understands multitasking. But this is something that you should always understand. And you can be a mini neurologist in the unit. You can actually have them draw a clock. If you suspect somebody, ask them, can you draw me a clock? Give me a piece of paper. And they will have one-sided clock. So meaning all the numbers will be on the one side. And the side that is neglect, they will completely neglect the number on the other side of the clock. And that is a perfect testing for visuospatial functioning. If you have a neglect, you have them draw a line, straight line on a piece of paper. Ask the patient that, can you bisect the line right in the middle? Draw the line, just bisect it right in the middle. And they will bisect it way from the middle because they can't see the whole line. They only see the half line, and they will bisect the half of that half line. So this is a great test, simple pen and paper test. You don't need anyone to do it for this hemi-neglect syndrome. Okay, so we talked about all of these under that. Now, next talk is what pathway. So we talked about the where pathway, which is the right-occipital. Now we're going a little back, still occipital, but involving the temporal part of the brain, called temporo-occipital domain, which is called what pathway. What pathway means what is this, not where is that. So if I show you a pen, what is that? What color is this? And these are all controlled by that. So the object recognition, face recognition, so I recognize people's face, recognize my daughter, my father, my baby, recognize them is a function of this part of the brain. So if you don't have that function, you can't recognize your own family members. You can't recognize a pen or a pencil or a flower. You can name them. You can recognize them. Object agnosia, which is the agnosia of object. So if you give an object, they can't recognize or name what's the name of that object. That's called object agnosia. Prosopagnosia, again, don't worry about this term I'm saying. Prosopagnosia means face agnosia, means that's the agnosia of people's face, familiar face. So if you can't recognize even face like President Lincoln, so if you show a historic figures or Donald Trump, that everybody should recognize their picture, they can recognize. So you can actually do it in a, if they are young people, you can do it to the Hollywood magazine and give them the Hollywood actor, actress name, a picture that who they are. And that is a good test for those kind of, I'm sorry, yeah, so those kind of nausea testing. So in summary, this was the summary that we talked about, that visuospatial function, hemi-neglect, anosognosia, which is the denial of illness that I talked about, geographic disorientation, like when you go to Boston, you take a 95 north. When you go to Florida, you take a 95 south. So if you don't have that, you may be driving for 50 years, but you start the truck to go to Boston, take 95 south, end up in Florida. So this is what happened in geographic disorientation. We talked about balance syndrome, and finally we talked about Gerstmann syndrome. All right, so I think I covered that. So one of the other diseases that object agnosia part of the brain called temporal lobe does, also a lot of other disease can happen because of the dysfunction of that part of the brain. The most common disease is the schizophrenia in psychiatric illness. Schizophrenia, especially one type of schizophrenia called mesolimbic schizophrenia. Meso means mesial part of the brain. Limbic is that temporal limbic system where you have hallucinations and delusions. So this is the part of the brain controls that perception. So hallucination, delusion, abnormal perceptory impulse is a dysfunction of this part of the brain. And then temporal lobe epilepsy or complex partial epilepsy is also a dysfunction. Wernicke is aphasia is also aphasia, that is comprehension, inability to comprehend. I have a little story I wanted to share with you. I was a resident one day I was actually a chief resident. So I was in the 4th year residency, so I was controlling the entire ER consults and everything. So it's a really responsible job when you are a chief resident, because you have to supervise all the residents, ER doctors, consult for ER, any kind of neuro consult. So around Friday, around 4:30, finally I'm like, oh God, it's Friday, it's 4:30, I have half an hour to go, then I'm gonna party. I'm done for the weekend. I have a weekend off. I'm like planning for party and everything. So half an hour I have to go. I got a consult. I'm like, oh God, why now? Because the one consult means you're going to stuck there for another couple of hours. So I'm like, oh no, I planned so much. So their consult came. This is a gentleman, 79-year-old, and this is in Boston. I was a resident at New England Medical Center, which is in Chinatown. I don't know if you're familiar of Boston. In Chinatown, Boston, which is a really area close to a big train station called South Station, which is the biggest train station in Boston that has connection Amtrak coming from all over DC, Philadelphia, and everywhere. So this gentleman is a 79-year-old man who actually a resident of a nursing home in Providence, Rhode Island. Providence is our neighboring state in Massachusetts. So and that nursing home is right across the Providence train station. This gentleman somehow got out of the nursing home. He left from the nursing home. Nobody was watching him probably. He walked to the train station and he just jumped into a train. And the train was coming to Boston. And the train brought him to South Station. And he started coming towards walking on Washington Street, which is right off the South Station. And New England Medical Center is right off Washington Street. For some reason, he had a wallet with all his medication list. That was a good thing that he has. So he comes and he walked. I don't know why he was actually walking towards the ER. He walked near the ER triage center, where a triage nurse usually triage, everybody comes to the ER. The triage nurse also had a long day, like myself, and she was also looking for getting out of the ER. So she was probably in a rush. So he comes and walks to the nurse, and ER nurse said, oh, what happened? Do you have anything to show me? And he just has this paper from his wallet. He said, oh, I know why you are here. Maybe you just need a prescription refill probably, yeah? Because a lot of patients, they miss the primary care doctor on Friday at 5 and they come to the ER for prescription refill. So she's like, all right, I'll write you a prescription. So she goes and doctor write a prescription of the whatever blood pressure pill that prescription was written for. 5 minutes later, the triage nurse is still sitting there. The Boston Police Department brought this gentleman to the same nurse, and the nurse was like, oh, I just saw him like 5 minutes ago. What happened? And the police is like, oh, well, he was buck naked in the middle of the island waving everybody. So the same nurse then asked, oh, maybe he's just homeless. Let's get a social worker to find. So Pine Hills is a homeless shelter right behind New England Medical Center. So she's like, well, I'm going to ask the social worker to find a bed for tonight at the Pine Street Inn. So the social worker comes. Social worker, in the meantime, the patient is not even seeing a regular nurse for a blood pressure or anything, or a regular doctor. Forget about the doctor, not even a monitoring, because they think it's a prescription refill. Social worker comes, she found the patient is completely confused, doesn't even know what they are. So this is how social worker initiated immediate consults, and I got involved. So I went to see patient is completely confused and disoriented, not times 3, disoriented in all modalities. So then I asked, let's get the blood pressure running. So we had the blood pressure, his diastolic was 220. Like, oh my God, immediately take him to the CT scan. So we gave the blood pressure medicine, take him to the CT scan. He had a stroke in the temporal cortex. So, oh, I write so much that I hope I can find a blank one. I don't think I have one blank. Oh no. All right, let's try here. So this is the temporal part of the brain, and here is the Wernicke's center, and here is the frontal part of the brain, frontal lobe. It is called Broca's area, which is our fluency center for the language, and this is the comprehension center for the language. This and this combined together make an arc, and this is connected like a language circuitry which controls our language every day. So I can be fluent, I can talk, and I can understand what you're talking to me for. So the fluency, comprehension, and the ability to repeat what you say, it is the circuitry pathway. So this is the language circuitry. So he had a stroke on this area, Wernicke's area. So what happened is he was fluent, he can talk, he had no problem with expression. He doesn't have an expressive aphasia. But he has a Wernicke's aphasia, which is the aphasia to comprehend what you're talking. So it's like walking in China when you don't understand Chinese language, that you have no idea what that people saying. So they look like sometimes psychotic, because people sometimes even call them psychotic, because they look like gibberish talk. They look like they're not really understanding. So that gentleman actually survived. That was a success story. He went into the neuro ICU, and he had a completely reversed the stroke. He had a TPA within 70, I think it was the stroke immediately within 3.5 or 4 hours window to get a TPA, which is a lifesaver for stroke. So he survived. But this is another symptom of this temporal lobe, Wernicke's aphasia. So if you have patients who look gibberish or not understanding, before you call them psychotic or not understanding, make sure they don't have a high blood pressure or a stroke or anything that can cause the Wernicke's aphasia. And then the rest of the stuff, especially this is interesting, musical hallucination. So hearing music playing, it's a very well-known music center, which is the fusiform gyrus in the temporal lobe, which is our music center of the brain, which controls perception of music. So this is the center, it's very close to hippocampus, which is our memory center. So because of that, a lot of earlier diagnosis, before earlier memory problem, a lot of Alzheimer's patients sometimes have musical hallucination before they even have memory loss, because this is the same area. And then similar is the olfactory area and the hippocampus. So loss of sense of smell and loss of perception of memories, music, or having perception of music when there is no music, like hallucination, can be a symptom of dementia. All right, so I think we talked about the visual cortex already. Um, so what I'd like to talk about is I think I covered a little bit on the hypothalamus, the mammillary body. Talked about the emotional circuitry and the limbic system on my first slide. But this is basically the entire hypothalamic function. So it regulates hunger, it regulates thirst, it regulates body temperature regulation, it regulates sex drive, behavior, emotion, pituitary gland, and of course, we all know circadian rhythm, which controls our sleep-wake cycle. So this is the circadian rhythm that get dysregulated because of loss of melatonin when we have dementia, and we call it sundowning. So evening becomes day, day becomes evening for them. So this is a very common circadian dysregulation symptom. One of the other things that I'm just rushing because of the time is this emotional pathway. So the same limbic system which controls our memory also controls our emotion. So emotion is a vital, oh, here I see the emotion. Oh. So I'll give you an example. The emotion, like, feeling good, feeling sad, feeling angry, feeling frustrated, feeling violent, aggressive, these are all dysfunction of this pathway. Now, emotional pathway has to talk with our frontal lobe. So this is they call it dorsolateral prefrontal cortex, meaning dorso means back, lateral is the lateral part, prefrontal cortex, so it is right before frontal cortex. This is the regulatory center for executive function as well as ability to regulate behavior. Okay, this that's how we function every day. God has some kind of homeostasis in our body. So everything, if you are too high with a glutamate, there is a GABA which will inhibit that glutamate. So you don't like jumping all the time. You are grounded because your glutamate and GABA is completely balanced. So when you lose the balance, you either become high glutamate, meaning what? Seizure, meaning what? Bipolar or hyperactivity, or too much GABA means what? Down. So there is always a homeostasis. We call it cortico, means cortex, limbic, cortico-limbic pathway. So not to be the sidetrack, but one of the major non-pharmacological treatment that also interact on this pathway is yoga. And as you know, not being a neurologist and a neuropsychiatrist, I'm also a yoga teacher. So this is actually, yoga does the balance in cortico-limbic pathway. So let's come back to neurology. So cortico-limbic pathway is the pathway that regulate basically too much dryness and too much crying or too much emotion. We don't want to be too dry, sense loss of any sense of humor or anything. That's the frontal lobe, that kind of daddy of the house. So I call it daddy of the house, not to stereotype daddies, but, say suppose a teenage girl has started dating, comes home and say, hey, mommy and daddy, I have a new boyfriend. So the mommy will say, emotion, women has more emotion, say, oh, I'm so happy for you, honey. That's so wonderful to be in love. And the daddy's response probably, well, that's good, but what does he do? Does he have enough money to support you? That's kind of response. So the frontal lobe is like a daddy. Frontal lobe is pretty dry, straightforward. Hey, do this, do that, have a good planning, have a good organization, make sure you're doing the right thing. So differentiate between right, wrong, to the point, no emotion. Whereas limbic system is, oh, I love you, emotion, that. We need both. So we need to have a balance between this cortico-limbic pathway. So depression, bipolar disorder, manic depression, anxiety disorder, these are all dysfunction of this pathway. Going back again, yoga is a great therapy for all of those because this is really a great cortico-limbic grounding pose that they have, a lot of poses that they have. So this is something that you should remember, that emotional pathway. The other thing that this pathway does also addiction, because it has a lot of dopamine in this pathway. And this dopamine is the reason for doing things over and over. So, I picked on men, but let's pick on women now. So women are pretty chocolate lover, yeah? We all love chocolates, and especially red chocolate. What do? We break up, cry, get depressed, and grab some chocolate. Why? Because we're self-medicating ourselves. We self-medicate when you're depressed, because when depression means loss of dopamine, and this chocolate has phenylephrine. Phenylephrine is a precursor of dopamine. So it makes you feel happy, makes you feel good. Love is also a function of dopamine. So give you an example from my previous few years ago. My yoga instructor, Michelle from Plymouth, Massachusetts, she's like me. She's very much into doing presentation and this and that. So one day I went right before Valentine's Day. I said, hey, Michelle, I have an idea. I want to do a workshop on Valentine's Day. And she was like, oh, great, honey, let's do it. What is the name? What do you call it? I said, I wanted to name the presentation as, will you be my dopamine? She's like, what does it mean? I said, well, a Valentine's Day is, will you be my love? Will you be my Valentine? Love is all about dopamine, because the dopamine causes attraction. Because of dopamine, we fall in love. So loss of dopamine means breakup, meaning crying. And if you have too much dopamine, what happens? So having dopamine means you are attracted to each other. You feel high. It's like a drug, yeah? So first time in love, oh, you feel like, oh, he's so good. I'm like the best. I found the best, but I'm so happy. I'm so giddy. And then you break up, you lose that dopamine. What happened? Oh, God, I didn't even remember him before like this. No, whatever I was thinking. He's a jerk. He did this to me. I didn't even see that. Now you don't have dopamine, so you don't have that. So increased dopamine sometimes means what? Hallucination and schizophrenia. That's why we give antipsychotic, which decrease the dopamine. So I called Michelle. I said, love is a form of psychosis. It is a form of psychosis. It's like schizophrenia. When you fall in love, you lose the inside of other person. You completely lose the inside. And then when you break up, you see everything clearly. Oh God, what do I was so wrong. So I said, dopamine, so that people understand it's not the person, it's the dopamine. That's why you're falling in love. So instead of calling, will you be my Valentine? She said, no, we don't want to discourage people to fall in love. And all right. So this is what the addiction and the love, pleasure, psychosis, they are all part of dopamine. What is dopamine means Parkinsonism. Dopamine means lack of movement, lack of emotion. So depression, Parkinsonism, apathy, motivation, lack of motivation is all due to lack of dopamine. So schizophrenia in one end, too much dopamine. Parkinson's disease on the other end, no dopamine. So they are like an opposite mirror image of each other. So if you're giving antipsychotic, which they're going to do, decrease the dopamine. But if you give too much of it, they're going to make you Parkinson's, because that's called Parkinson's disease. Same thing happened with Parkinson's disease. If you give too much dopamine, like Cinemet, which is a good thing, the movement, but if you give too much of them, they're going to start hallucinate. They're going to start delusional, because they become schizophrenic. So it's a very thin line that's very hard to control by both neurologists and psychiatrists for these two diseases with the medication, because of the one push the other. So this is the circuitry that I was talking, just for academic purpose, for memory. So I think I talked about all the memory pathways. So the gist of the presentation, we covered the motor learning, the spatial attention, geographic orientation. We covered the neglect syndrome. We covered the balance syndrome. We covered the Gerstmann syndrome. We covered all kinds of temporal diseases, including benzyme. So all the things that we have, forget everything I said. And if you want to go home, dementia does not, somebody has a perfect memory, it does not mean they don't have dementia. They probably doesn't have that memory domains, but may look for other 5 domains that I talked about. Aphasia, the language domain, apraxia, the parietal cortex domain, agnosia, the visual recognition domain, and executive function, absence of executive function. Okay? So module 2, all the 5 domains, these are the, to be just memory. It can, memory is one of them, but it can be the executive function. In fact, that is the biggest one. Disease like vascular dementia, disease like dementia, all kind of dementia, non-Alzheimer's dementia, where your memory doesn't really, visuospatial, getting lost in driving, lost in familiar places, problems with the health, dressing, bathing, that can be a cognitive domain. Just alone can cause dementia. Language, then all kind of different things. So the finally, with head, the mind, and the sleep, that no matter what we call our, or a scientist or a nurse, we are got to have that passion. We talk to them. It means nothing. It's not like we are word. All the see the eye of the passion as well as so don't interpret behavior as behavior. The rule change. They don't need a pill. They may have to modify the neuron because they are lost in the neuron. If the behavior is because somebody is screaming and they are just can't take anymore, it's too overstimulated environment, or if the behavior is because they see properly, and then get an eye appointment, or they can't eat, they get a dental, or they can't hear, get an auditory appointment. So these are simple, and then after all those, if you still feel they have some kind of behavior, then make sure the primary care does all the medical testing to rule out any acute delirium caused by an infection, dehydration. If all those ruled out, still having come to us or get any neuropsychiatrist or anyone. But our job is not, our job is to to the next person when I'm going to be leaving. So that this is a 24-hour cycle of work and get kind of understanding what's happening with the patient and the residents. So in my last slide, this is from Buddha, and I always use it. And people who know me know that I always with this slide. This is my passion. This is my heart. Buddha actually said, in the end, only things matter. No matter how much money you have, no matter what you have, whatever you have, you're not going to take anything to the grave. Only 3 things matter. Number 1, what you loved. Number 2, how gently you lived your life. And number 3, which is the hard for me, how can you let go things that don't mean for you anymore? You know, holding back everything from our past, we don't move on. And we are not opening our heart for new things. So you can't approach, you can't open your heart when you really, your heart is closed. You're really holding back from the past. So that all the trauma from the past, all that experience from the past, dementia. This is a slide that I have handed out diagnosis. I am a family meeting with a big classroom in the clinic, and that I tell them that just let go all the things that I said and just find yourself the soul and find still good. You're still the same person as you are. That's never going to change. And find the ability mode, find the strength where you can work things better rather than crying for what you lost or what you don't have. Okay, with that, I'm going to stop.